I'm Dr. Randall Sechrist, your host for eOrthopodTV. And today we'll be talking remotely with Dr. Brett Fink. Dr. Fink is an orthopedic foot and ankle surgeon who practices in Indianapolis. He now currently serves as the president of the Indiana Orthopedic Center. Dr. Fink completed his medical school at the Washington University School of Medicine in St. Louis, Missouri. From there, he completed an orthopedic residency in the Portsmouth Naval Hospital. And from there, completed 2 foot and ankle fellowships, one at the University of Miami and the other at Boston University. Thanks for joining us today, Dr. Fink.
Thank you very much, Randall. It's a pleasure being here.
Well, today, Dr. Fink, what I thought we would talk about is a fairly common orthopedic foot condition, and that's hammer toes. So if you would, start out by talking a bit about what causes hammer toes and how patients know that they have hammertoe deformity.
Well, that's a good question about it as far as what causes hammer toes, because I don't think that really anyone knows. They seem to be a degenerative condition, meaning that as you get older, they become more and more common. And it seems to be related to some damage that occurs to some of the small joints in the ball of the foot. These joints to doctors are known as the metatarsophalangeal joints. When these joints become damaged, a lot of times the posture of the toe will begin to change. It could overlap other toes, or it could actually raise up and the toe can become curled. As far as what causes it, age certainly comes into it. The way that you use your foot probably does, but it's difficult to really identify this in the scientific literature. But it is a very common problem, and it's one of the main things that I see in my clinic.
So in terms of the symptoms that a patient may experience from a hammer toe, what's the worst set of symptoms that patients typically complain of?
Well, for each patient it can be a little bit different. I would say that the first problem is commonly pain in the ball of the foot. People can have unexplained swelling in this area. A lot of times in my practice, I've got to figure out whether this is this ligament deterioration that I've talked about, or whether it is a stress fracture. The physical examination is subtly different. Often, the swelling and the pain will go away in the ball of the foot and will be replaced by the toe deformity. And I think that most people that have had a hammer toe know what the toe deformity looks like. The toe begins to look curled. The middle portion of the toe, what we call the proximal interphalangeal joint, can start to cock down so that the knuckle on the top of the toe becomes much more prominent. And later on, people can either experience pain on top of that knuckle when it rises up and hits the shoe, or even at the tip of the toe when it hits the ground at an unusually acute angle and becomes uncomfortable to them.
Now, are hammer toes associated with any other disease processes? Is this something that just comes out of the blue, or do you expect to see other problems that are maybe hammer toes are related to?
There are a lot of associated problems that can occur with hammer toe. One of the most common is a bunion deformity. When bunion deformities form, there's not enough pressure on the big toe, and a lot of times the pressure moves over onto the second toe. And in my belief, this mechanically wears out the toe so that the hammer toe occurs more frequently. Other things that can be associated are things like rheumatoid arthritis, diabetes. It can certainly be a part of a diabetic foot. And as people get older, this becomes more and more common.
Well, we probably should explain, at least briefly, what a bunion is to people who may not be familiar with that term. Can you sort of maybe give us a description in general what a bunion is?
Sure. Literally, a bunion is a prominence on the inside of the foot, but it usually occurs in the ball of the foot around the big toe. And basically what happens is that the metatarsal, the long bone in the arch, starts to point towards the midline of the foot. The other part of the toe begins to angle the other way, making the joint very prominent. And what people with bunions generally have is a prominence or a point at the inside border of the toe, which pushes on the shoe and makes it very uncomfortable.
And let's move on and talk a little bit about the symptoms that patients may experience that will bring them to a foot and ankle surgeon. What do you think brings patients into your office more commonly?
Well, most commonly it's the unexplained swelling, but also people can come in because of the toe deformity. They just don't know what it is. Some of them think that they've broken their toe, and this may prompt them to come in because the toe becomes very angled.
Is there anything that patients should worry about when they see these deformities? Is this something that they definitely need to get in and see an orthopedic foot and ankle specialist right away, or is this something that maybe they can sort of tolerate for a while before they choose to do anything?
Well, I think the important thing is to make sure it's nothing other than a hammer toe. Again, if they had a fractured toe, especially a stress fracture, which can occur without any problem prompting it, a stress fracture can occur without an actual trauma to the foot. And it's important to make sure that it isn't a stress fracture, because if it were a stress fracture, you'd want to protect that. In certain circumstances, it may cause the toe not to function very well, and this is something that's preventable. On the other hand, a hammer toe itself is never really a emergency. Like I said, it's just important to look into and find out whether it's something else.
Well, let's talk a little bit about diagnosis. When a patient presents to your office with some type of a foot deformity, they may or may not know what it is. How do you begin the process of trying to make the diagnosis of a hammer toe?
Oh, well, certainly the most important thing is to ensure that you do a careful physical examination. And I really think that these physical examinations are best done by people that are familiar with these problems. If you go to a primary care physician, a lot of times this isn't the thing that they're going to see day to day, and so they may not know exactly what it is. And a lot of times they're very confused about whether it's a stress fracture versus another diagnosis. As far as the physical examination is concerned, certainly in someone that is very good at examining the foot, a hammertoe deformity is obvious when they see it. It's important to carefully identify where the pain is, because generally the pain occurs in fairly predictable areas. If you have pain that isn't in one of those areas, then that's a problem. So the pain is often directly where these injured ligaments are, and those tend to be right at the bottom of the foot in the ball, located directly over where the bones and joints are in the ball of the foot. Other areas that may become painful later on are areas where there might be a corn or a pressure area developing around a foot deformity. It's also important to identify other medical problems that might be going along with this, because they might affect how you go about treating it. In someone that has diabetes, because they may lose some of the sensation in their foot, the diabetes may affect how you treat the hammer toe itself. You may want to protect a hammer toe in a diabetic foot much more carefully than you would in someone that has normal protective sensation.
And what about imaging? Do you find that x-rays are necessary? Any advanced imaging such as MRI scans or anything like that that you recommend in evaluation of the hammer-toe deformity?
Well, I think that x-rays are almost always a good idea, because take for instance the case of a diabetic again. You'd want to make sure that that person really wasn't having some kind of diabetic stress fracture, which is very common in people with diabetes. You'd also want to make sure that there's not some type of destructive change going on in the joint that might explain the deformity more completely. And you want to make sure that there's not an obvious stress fracture that's been there for a while. As far as further imaging techniques, there are a lot of scientific studies that have looked at MRIs or bone scans. However, in my opinion, they rarely change what I do, and so I don't get them as a routine.
So an MRI scan is not something you're going to order on the first visit, but you probably are going to order x-rays on the first visit when you see that patient. Is that accurate?
Yeah, and I would say that when you see a subspecialist with a foot problem, that they're going to want to get x-rays as a point of routine almost all the time. But in hammer-toes, I would really say that they're something that I get on a routine basis.
Okay. Well, let's talk a little bit about treatment. Once you've made the diagnosis of a hammer-toe deformity, how are you going to start the discussion with the patient about what is necessary for treatment?
Well, my first visit with a patient is always centered around education. I think it's important to give the patient some insight as to what is going on with their foot, because this is very scary to see that your foot has changed in alignment. I also help the patient understand that this isn't something that needs emergency surgery, and there aren't usually any problems that can be made worse by observing this for a while. And I find that observing it is really the initial treatment. It's also important to kind of give them an idea of why this has happened. A lot of people blame themselves for these deformities. They blame their high-heeled shoes, and let's face it, every woman has worn high-heeled shoes in the past, and so if high-heeled shoes were the blame for every hammer-toe, then everyone would have hammer-toes, and everyone doesn't. So it is more or less a combination probably of their genetics and the activities that they've done. After that, we talk about the problem, and really the treatment is geared towards the problem itself. If the problem is really swelling and tenderness, then we discuss certain shoe wear restrictions that they can do that might help take some of the pressure off of this. I have found rocker-soled shoes, while they are kind of not as popular as they once were, are very helpful in decreasing forefoot stress. And so I send them out to look at rocker-soled shoes to see if these might help. Occasionally, I will do a steroid injection. There is some controversy about steroid injections, however. Steroid injections can potentially decrease the metabolism of some of the cells that are trying to repair the areas around these tears. So some people have suggested that steroid injections might actually make a hammer-toe deformity develop in someone that doesn't otherwise have it. My own feeling is that until there are definite studies that say that steroid injections are a bad idea, I continue to do them. I have not found in my own personal experience that I often see a worsening of the hammer-toe deformity after a steroid injection. I believe that they are safe if they're done in a reasonable manner, meaning 1 or 2 steroid injections, not 6 or 7 or 8 or 10. Beyond that, and that's usually where we go with the first evaluation. I also often start people on stretching exercises. I think that ensuring that the Achilles tendon is flexible enough is important in reducing forefoot overload.
Now, we've talked a lot about sort of controlling the symptoms of the hammer-toe deformity. Is there any way short of surgery to actually improve that deformity? And what I'm talking about is the looks of the toe or the way that the toe behaves. Anything you've found that's useful to impact that rather than surgery?
Well, as someone who has suffered from a hammer-toe deformity myself, if there is a way, it's not listed in the literature and I haven't found it. I tried several methods when my hammer toe was developing on my right foot, of taping the hammer toe into position, of wearing various braces, and nothing has seemed to help. And if you look back at the underlying problem, this degenerative tear, it's hard to believe that positioning the toe is going to particularly allow that weakened ligament to regain strength. So I'd have to say, unfortunately, once it's developed, the horse is out of the barn. The hammer toe is going to do more or less whatever whatever it's destined to do, and there's not much you can do about it.
Now, what about physical therapy? Do you use physical therapists to help people with the Achilles stretching and perhaps some of the symptomatic relief, or do you feel that most patients can be taught to do this on their own?
I usually have my patients, I have some materials that I give the patients to kind of start them on an initial stretching program. I don't think that therapy is necessary for something so simple as this. However, in my own clinic, and this is, there's completely no scientific evidence about this, I feel that strengthening the intrinsic muscles is an important part of recovering from a hammer toe and preventing problems like hammer toes in the future. So often I will send patients to be taught a home exercise program that includes some intrinsic exercises, some exercises that focus on the small muscles of the foot. And these are a little bit more complicated, and I do feel that the help of a physical therapist is often very helpful in these.
Well, let's talk a little bit about surgery and surgery for the hammer toe. You mentioned in diabetics you like to sort of stay away from surgery if at all possible, be very careful with that population. When you're sitting down to have a discussion with most patients about when it's time to consider surgery, what's going to drive you to start that discussion?
Well, most of the time it's my patients that drive me to these discussions. My own bent on hammer toe surgery is to be as non-operative as you possibly can, because I find that with the hammer toe surgeries that are available and the costs and the trade-offs that you make during surgery, that often, unless the problem is significant and severe, that they are not helpful with, they are not particularly happy with the results after hammer toe surgery. So I generally, again, discuss on the initial visit my own feelings about hammer toes, the fact that a lot of times they do go away by themselves, that the pain goes away, but the deformity persists. And if they are able to live with the deformity, and again, a lot of these patients are at least middle-aged, if not elderly, a lot of times they've found that there are a lot of problems that they more or less have to deal with just as a matter of life. In those patients, I encourage them to live with the problem. If it is really not something that they can handle, if they have difficulty finding shoe wear that fits them properly after a good attempt, or they have persistent pain after months of non-operative treatment, then I think it's reasonable to consider this. But when I'm discussing surgery with them, I emphasize the fact that the toe really doesn't work like normal after a hammer toe surgery. It's stiffer. Sometimes the position isn't exactly where they want it. And so, again, unless there's something specific about the hammer toe that they just don't like, we don't rush off into surgery.
Well, I'm curious, you'd mentioned that a lot of patients are not satisfied after what you would consider a successful hammer toe surgery. What is their dissatisfaction? What does that stem from?
Well, I think that people like to have their toes function normally. And unfortunately, after a hammer toe deformity, the toes never regain the flexibility that they have. You never regain quite the motion that you'd like. Sometimes the incisions themselves cause some numbness on the top of the toes, and people don't like that feeling of numbness. But even though I myself am very careful when I'm doing these surgeries to ensure that I don't interrupt any major nerves, the nerves, as they get out into the toes, are really the size of hairs, and it is very difficult to keep from damaging some of them. And so a little numbness on the top of the toe is something that a lot of people don't like. The recovery after the hammer toe surgery is often prolonged. There's often a great deal of swelling that can go on for 4 to 6 months, at times even longer.
Can you describe for patients that are watching this, in general, how hammer-toe surgery is performed?
It depends on several aspects of the patient that probably a doctor is only going to be able to decide. But in general, we approach every joint of a hammertoe deformity individually. In my own practice, I usually repair the ligament that has been torn on the bottom of the foot to regain the posture of the joint at the ball of the foot, called the metatarsal phalangeal joint. And often this repair is through tissue that's not the best, and so we often have to steel other tendons that are in the area in order to reinforce this. Usually this involves pinning the joint for a period of time, and sometimes we have to shorten the metatarsal in order to decrease the prominence of that bone. Then we approach the other joints in the foot, the proximal interphalangeal joint, or the PIP joint, which is the first joint in the toe itself. And a lot of times we have to release the ligaments or straighten it or use some kind of ligament transfer technique in order to get the toe straight. And often after these techniques, the toe is very stiff.
So this is a very complex surgery you're describing. This is not simply a small incision with a release or something of that nature. This is a very complex, involved surgical procedure as you're describing it. Is that accurate?
I believe that it is. And unfortunately, you would like to have all your surgeries to be complete repairs, to take a damaged structure and fix that and not have to interfere with anything else. Hammer-toe surgery, unfortunately, is not like that.
Well, let's talk a little bit about complications. You know, it seems like that clearly one of the complications is the stiffness that you have already described, as well as the maybe some deformity that still remains. Any other complications that you worry about as an orthopedic surgeon that might affect the outcome of this type of surgery?
Oh, I think there are a number of complications. Certainly, there are the complications of anesthesia, which you've always got to think of, because most of these surgeries can be done under local anesthesia, but in general, I think that most practitioners use a general anesthetic or an anesthetic that puts you to sleep. And there are the complications of that, which, you know, in rare circumstances can even mean death. But the complications that are more specific to a hammer toe are problems with the blood supply to the toe. When you straighten out a toe that has been bent for a while, a lot of times the vessels will spasm and the toe can lose its blood supply. And in certain circumstances, people have lost their toes after hammer-toe surgery. The ones that affect the patient's satisfaction most are probably residual deformity. And unfortunately, after repairing these ligaments or doing whatever your doctor decides is best, there can be some residual deformity. A lot of times if the hammer toe crosses over the big toe, which is a very common deformity, the toe, even after a successful surgery, will tend to lean towards that side, and people can find that very troublesome. In addition, it can lift away from the ground so that the toe doesn't touch the ground quite like you'd want it to. Numbness, as we talked about before, wound problems with the skin on the top of the foot. Especially in an elderly patient, the skin can be very thin. And as you're moving and retracting and repairing things, it can damage it. And I have seen people that have lost some of the skin on the top of their toes. Now, usually this requires only dressing changes, but it can be psychologically troubling to a patient to have a wound on the top of their foot after what they thought was an elective surgery.
Well, I think this has been a wonderful discussion that has pretty comprehensively discussed the whole concept of hammer-toe and the potential diagnosis and treatment options as well. do you have any advice for patients that may be trying to make these decisions and are watching today that you've learned both through your practice as well as your experience with Hammertoe yourself? Anything that you would really want the patients to know if they're watching this?
Well, I think the most important thing to understand is that a lot of times the pain will resolve on its own. One study that looked at this showed that 60% of people end up with a deformity, but the pain goes away. And in people like that, I think that it's a good idea to wait and watch and not get too upset and worried about what might happen. Unfortunately, foot deformities that do not interfere with shoe wear are almost a way of life and just a natural part of the aging process. And if you do decide to go ahead with foot surgery, discuss with your doctor and find out very clearly what the expected function of your toe is after the procedure. A lot of times, as you mentioned before, people think, it's just a hammertoe surgery. But people can have an idea of what they think the toe is going to be like that may not reflect what their doctor expects it to be like. And so a clear and concrete discussion of what is expected after the surgery, I think, is very important. Beyond that, just try to use proper shoe wear, try to find shoes that don't press on the toe, and a lot of times people can tolerate this for the rest of their life.
Well, I think that's excellent advice, and I want to thank you for sharing this with us today and with the patients that are watching. So thank you very much, and I look forward to future discussions on different orthopedic foot and ankle problems in the future. Thank you.
Thank you very much, Randall.